Good afternoon. I've already been introduced, so I won't do it again. It's nice to see some familiar faces. I think it's 5 years since we were last here doing this, and I'd like to say thank you to TOFS for inviting me back. Some of the slides we'll use today are the same, but I think that's because they relate to similar things, but we've made some changes, and today I'm going to talk about the gastrointestinal issues that are faced throughout life after esophageal atresia repair. So back in the 50s and 60s, when people were first repairing esophageal atresia, it was very much a focus on survival. And we know now that really we need to be focusing on the rest of that individual's life. So you've already heard today from Dr. Thursfield talk about respiratory impacts. I'm going to talk about GI impacts, but also there's the musculoskeletal impacts, which we are less well advertised, or less well advertised, but discussed, but is something also we should bear in mind. So today we're going to talk about swallowing difficulties, reflux, and a couple of long-term issues that people often ask me about, and I think are hot topics. PPI use long-term and the safety of that, and then Barrett's esophagus, which Chantal just mentioned. So swallowing difficulties. Why do we get swallowing difficulties after esophageal atresia repair? Many of you will be familiar with this, but the one that we normally refer to is at the site of the repair we get strictures. And you can see on the left here, they can be quite dramatic. We can see a really small pinhole here. And the reason why these strictures occur is because at the site of the join, where we're joining a big dilated upper pouch to a smaller distal pouch, we often have to stretch that tissue to bring them together, and the blood supply and the tension, the trying to draw them apart, means that the vascularity and the scar tissue that forms around here can predispose to that, and they can be very problematic, as you're aware. So that's one anatomical reason why things may get stuck. There are functional reasons why things might get stuck, and a lot of work's shown that the motility of the esophagus, so the muscle fibers and the way those contract, the esophagus should be like a snake swallowing something. You know, when you see a picture on the TV of someone, a video of a snake swallowing something, there's these rhythmical muscle contractions that propagate down the snake, and our esophagus is like that, and we call that motility, and we know that doesn't work well. And there have been studies to show that the esophagus in esophageal atresia doesn't do that as well. Interestingly, I was talking to an adult TOF just today who was explaining to me that their motility's got worse with adulthood, and that's not something I've experienced, and I find that fascinating, and obviously it's something we need to think about. Finally, there are other reasons, other anatomical reasons why you may have swallowing difficulties. And here you can see a second narrowing in the distal, so lower esophagus. And this can be from a number of reasons. It could be reflux related, and a reflux coming up, inflaming the esophagus, and then that healing and forming a reflux stricture. We see that, I would say with the medications now, less frequently, but can occur. But also something that can be missed is an anatomical congenital problem. So you're born with a second narrowing. We've seen this, it is quite rare, but it's something called congenital esophageal stenosis. And it all comes back to that embryology before the baby's born, about the two tubes separating, which is why we get OA in the first place. But actually there can be another problem where part of the trachea is actually in the esophagus, and a piece of the cartilage, those rings that you can feel at the front of your trachea, can actually be present in the esophagus. It's quite rare, but unless you go looking for it, you may not find it. We've found 3 in the last 7 years in Manchester, and they need removing. So they need a second operation to remove that area, and that can be difficult, and it means you end up with 2 joins in your esophagus and can be very problematic. But if you don't do a contrast study like this in the newborn period, you may miss it, and it might not be till later in life that these are picked up. And it's one reason why I would advocate that all babies should have an esophagogram, and I know that's not universally done. We've published a paper that shows it probably is more common than we think it is, than many people think it is. So what to look for? Obviously, these are all pictures of children and babies, but applied to all, you'll be all very familiar, I'm sure, with this, but tricky in the newborn or the young baby, because milk-fed, they may have quite a significant stricture and actually not demonstrate that until they start choking, Or the earlier signs are probably taking longer with the feed, so taking longer to finish a bottle, or taking longer on the breast. Obviously, there's bringing milk back up, or frothing at the mouth, and then there may be food refusal in the toddler, or in the older child, we'll be able to tell you, and you'll be able to see all those signs of a sticky that many of you will be familiar with. Obviously, these tend to be worse with certain foods, and many of you will be the experts at that rather than me, but the stories I generally get told in clinic, it's things with skins on, it's the fruits with skin, or sausages, or meat, or chicken, but particularly sausages because of the skin again, and also bread can be a problem. So what does the research tell us? Well, I like this paper because it's got really good follow-up. It's 40 years is the average follow-up, but the youngest patient was 18. And this looked at nearly 50 patients and showed that 80% did still have swallowing dysfunction. It was obviously worse for hard foods, and I don't think that's a great surprise. And 3/4 of people needed to drink with their food to help. On the positive side, it was often mild and did not overall affect overall quality of life. So what can we do to help? Well, there's the obvious things, isn't there? There's the teaching children to eat slowly, to chew well, cut up food for younger children, drink with the meals. I think what I see is that children find a way of they just learn this themselves, don't they, through osmosis and through growing up, and quickly become familiar with what they can manage. Pharmacologically, we can manage the reflux, so we know that reflux and strictures are closely interrelated. So if you've got a stricture and you've got bad reflux, that stricture is not going to heal. So reducing that acid going up to that stricture is an important part of treating a stricture. There's the balloon dilatation, which is the most common method of doing this. So we put a wire down the esophagus and a little balloon over the top. And at first you can see there's a little, what we like an egg timer, which is we call the wasting of the balloon. And then when we've blown that balloon up with some contrast and taken some x-rays, you can see it's disappeared. And this is a little schematic diagram here, how it sits in the esophagus. That's very useful. It's the mainstay of how we manage difficult strictures. There are other more invasive techniques. You can put a knife down through a camera, so this is all via the mouth, or even in very problematic strictures, they occasionally require additional means, so we can inject steroids, or people have also used medicines and applied those topically. A little bit anxious about some of those because they're quite potent medicines that could cause long-term problems. People may have heard things like mitomycin. I've not used that. As I say, a little bit concerned about that. We don't know the effects of that long-term. But also, very occasionally, strictures are so difficult that we have to go back and remove them and excise them. So that would be a bigger operation through the chest again. So, moving to reflux, why do we get it? Well, there are very similar reasons to why we get swallowing difficulties. There are mechanical and anatomical reasons, and there are functional reasons. Anatomically, we know that when we've had to bring the two ends of the esophagus together, we're going to pull that stomach up to a degree, and sometimes that might be to a really great degree, and it might mean that the stomach inside the chest, and that can give you a hiatus hernia. But even if you haven't done that, you're putting things under tension that weren't designed to be under tension, and because of that, reflux is much, much more common, as you know. There's been a real interest around the world and in certain centres in the UK to do what we call traction repairs, or various stage repairs where you draw the ends of the esophagus in a long gap situation together. And anecdotally, it sounds like that is going to cause more problems with reflux. Other situations where reflux might be more common would be if you have things like a gastric transposition, so stomach in your chest, a gastric pull-up, or if other anatomical reasons of the stomach have been disturbed, because our body has normal defences against reflux is probably the best way to put it. Functionally, we know, again, we've talked about that the muscle doesn't always work and it doesn't clear the fluid in the esophagus, so you may not only get gastroesophageal reflux, so fluid and food coming up from the stomach up into the esophagus, but also intraesophageal reflux, so fluid that's in the esophagus going the wrong way, and obviously that's all interrelated to the dysmotility. And the effects of reflux are, as we'll have talked about today, they can affect the lungs and the airways, and they can affect the esophagus itself, and all of these sorts of things you can see there and then will no doubt be familiar with. The complications of reflux, I'll focus on the GI ones because I'm sure Dr. Thursfield's talked about the respiratory ones. Esophagitis, so inflammation of the esophagus, and we mentioned earlier about that then healing and scarring and causing strictures. But obviously that can, particularly in the early years, if your reflux is really severe, you will actually fail to thrive because the calories don't stay down, and it's not infrequent that we have to do something about that. And that can impair quality of life and predispose to this Barrett's esophagus, which we've talked about. So how do we manage reflux? Well, there's the simple methods that you'll know, so changing milk, feeding slowly, keeping upright, avoiding certain foods. We know that certain foods are bad. My patients come and tell me, as one young lady who I remember who's a teenager now and tells me that, you know, she has fish and chips, then she'll pay for it, but she just has to judge when she's going to do that, and have some Gaviscon on hand. Obviously we can prop the bed up and things like that. Pharmacologically, we'll cover that in a minute. There are a number of options, and then occasionally surgery. It's probably worth touching on that sometimes reflux can be managed by feeding by different routes and can be so severe sometimes that we have to feed either via tube and gastrostomy, but also into the jejunum. So some children will require either a jejunal tube as a baby, that may be through the nose, but then can be via either a feeding jejunostomy or a gastrojejunal tube. Reflux surgery, fundoplication, I would say, still remains the mainstay of that. If your reflux is so severe that it's causing complications that can't be managed with medicine, then we would consider fundoplication. It can often be done by keyhole surgery. It's not a perfect operation, but can be very, very useful in esophageal atresia and can help strictures heal. It can help particularly if you're having these life-threatening events as a baby due to severe reflux, it can be very, very helpful there. I'd say the fundoplication rate, it does vary. The published literature says up to a quarter or even more. I'd say we're a bit lower than that in the UK from talking to other surgeons, but certainly a good number of children and adults do require anti-reflux surgery. So our options to treat reflux, we can obviously change milks. We can use hydrolyzed formula, so milk that's easier to digest, thickeners and Gaviscon, and then PPIs, which we're going to talk about a bit more in a minute. One thing I wanted to draw was this drug here, famotidine. Many of you will know that ranitidine was withdrawn a few years ago now due to concerns about its safety. Famotidine is not easy to get hold of. A lot of pharmacies struggle to get it. GPs are reluctant to prescribe it. Our gastroenterologists are quite keen on it, and I've certainly seen some real benefit from using it with some older children. And so I'd recommend if you are struggling or know someone that's struggling with their acid control, then that's definitely worth exploring. Prokinetics such as domperidone or erythromycin, the antibiotic, can be used. I think the effectiveness is quite variable, and obviously with domperidone you do need ECGs and things to monitor the heart. So looking at the safety of PPIs, I often get asked about this. It's a difficult situation to look into. There's a wealth of literature out there. It can often be quite conflicting, and it's easy to get end up in diving into rabbit holes of conflicting things. But I've focused really on these two big studies, one from the American Association and this huge paper with a couple of million individuals' data involved in Nature. And so the difficulties of looking at PPIs are it's very difficult to separate association and causation. So just because you have a PPI, you're taking a PPI, doesn't mean that's causing the risk or the problem. So if you look at ice cream sales and shark attacks, obviously it's a silly example, but they both peak in the summer, but no one's going to suggest that ice cream sales are responsible for shark attacks. And similarly, we don't know that PPI use, it's actually causing the problems that they're associated with. Relative risk, we may change the relative risk to them quite a lot. So a wonder drug might reduce heart attacks by 50%, but if they're only 1 in 100, or 2 in 100, then you're only reducing it to 1 in 100, so they still remain very rare, and that's the same with a lot of these PPI risks. And similarly, confounding factors, because you may develop problems, but it might not be actually the agent, the PPI, that's the problem. It might be something else that goes along with that. So this one here, coffee and cancer might be associated, but smoking might be more common in coffee drinkers. I'm not saying that's true, but that could be. So you may have a confounding factor. So if we look at, this is one of the very, very big studies, and they looked at the quality of the evidence about, so PPIs have been linked with all of these things, from kidney disease, dementia, problems with bones, pneumonia, and malignancies. But actually, if you look at the quality of the evidence to support those associations, it is either very low or low in all of the cases. So it's difficult to draw firm conclusions. Once we look at the absolute risk of some of these things, so kidney disease, 0.1 to 0.3% per patient per year. So that's 1,000 to 3,000, so 1 in 1,000 to 1 in 3,000, or sorry, 3 in 1,000 per patient per year. So very, very low absolute risks. And actually, the one that we are most concerned about, gastrointestinal malignancy, there's been no associated, and no association found in randomized controlled trials, which are the best source of evidence. So in conclusion, what I would say is the absolute risk is very low. We need to balance the benefit of the PPI for the patient and just keep them under regular review. Do we need to stop those PPIs? So to touch on Barrett's, we've already talked, Chantal, about this change from the normal lining to this columnar lining. It's due to, or it's associated with that chronic reflux of acid. But there are controversies. How do we define it? Gastric versus intestinal is really important because we know that the risk of gastric metaplasia becoming a malignancy is a lot lower than intestinal. So actually it's intestinal that we're most concerned about. We need it to be standardized, and we need to know what is the relevance to future risk of malignancy. So this paper is really excellent prospectively, so done going forward. They protocolized how they were taking it, 120 patients, and did show a really quite high risk of Barrett's in OA, 43%, but only one of the 51 patients with Barrett's had that intestinal type of changes. So I think that's really important to bear that in mind. This is from Nigel Hall's group in Southampton, and they reviewed all of the literature on Barrett's and looked at that prevalence being about 5% in OA patients, which is very similar to the data that Chantal just presented of 7%. When screening was carried out, it was a bit higher, it was towards 13%, and it was detected at a mean of 13 years, so it's that teenage age. So what is the real risk? Well, it's difficult to know because it's there, but is it going to cause a problem? We know from the population studies in adults that the progression to malignancy is quite low or very low. And actually, as I said, it's that intestinal type we need to keep an eye on. It's important to know that very few cases of malignancy have been reported in the world. In the Nigel Hall's paper I've just shown, only 13 cases were included in that systematic review. So what should we do about this? I think what we need to do is have a protocolized system to screen for this. And unfortunately, I think in the UK we're quite far behind the Netherlands, and I was looking enviously at the slides just presented from Chantal about how they're managing their follow-up in a structured way like that. It really is incredible to see. Unfortunately, resource limits what we can do, but at the very least, I think we should be screening all children before transition. In Manchester, we tend to go at around high school, so between 11 and 12, and then later on at transition. So if we know about the Barrett's, at least when we transition children, we can highlight that to the adult services. But then this is the British Society of Gastroenterology. They have a protocolized approach to how you manage the Barrett's. So it is important. Finally, just to touch, we're running out of time a little bit, but esophageal replacements, we know from Ed Hannon's work when he was in GOS, he's a surgeon up in Leeds now, he showed that individuals with a gastric pull-up tended to have high rates of anemia and symptoms such as dumping syndrome, and importantly, a fifth of those individuals required supplementary feeds. They had lower BMIs. As you would expect, they had more problems with reflux than the primary repair groups, but less problems with dysphagia. And then I'll just finish with this study, which I think is excellent, from 25 studies, over 1,000 patients. and they looked at some aspects, particularly of quality of life. And I think what is very positive to see that a quarter of OA individuals had none at all, and another 30% had little, and only, whilst it's still very significant, around 17% had significant impacts on their quality of life. So it's positive to see that many individuals are leading a very normal life. You can see here that their ability to form relationships is good, and the effect on, there does remain importantly an effect on members of the family. You can see here that some more significant impact on other members of the family, and I think we need to consider that. And then education and work. We can see here, obviously, focusing on the adult group here, about 40% had none at all, but then still a fifth of individuals did have a significant impact on their education and work, and that's a large amount. That's a fifth, 1 in 5. So I think this overlaps with exactly what Chantal's been telling us today. Okay, I think that's everything I've got to say, and thank you. This is our group in the neonatal surgery MDT, and happy to take any questions. Thanks.